Okay. Okay, so welcome to this CPD event, which is about understanding adults with ASD and ADHD. We'll just introduce ourselves first so you know who we are. So I'm Lisa Debrou. I'm a clinical psychologist and one of the clinical directors at HelloSelf, and I work alongside Femke, and we have a team who deliver assessments, both ASD and ADHD in adults, and we also do ASD assessments for children.
And I'm Dr. Femke Leathes, also clinical director at HelloSelf, and with Lisa we run Leathes Psychology, which is a HelloSelf clinic based in Reading, and the adult ASD and ADHD service that we have is held within that clinic. We set the ASD, the adult ASD service up last year, and the ADHD service earlier this year, really in response to demand that we were getting from two main sources. Firstly, from our existing client base, we also have a lot of adult therapy that goes on, and during the course of therapy these difficulties were coming to light for some of our clients, so that was sort of one thing that was going on. We were also getting a lot of inquiries from people asking for these assessments, so we thought, right, I think we need to do something about this, so we will talk a little bit more about the service and how that works. Just to say though that it's quite embedded in our clinic as a whole, which is brilliant because it's a very smooth and fluid experience for clients, both ways. If you've got a therapy client and these difficulties have come to light through the course of therapy, we're not having to signpost them off somewhere else to sit on a waiting list and a service that we don't know very well. There's a lots of sort of integrative working. It's a much smoother experience, and hopefully all the clients tell us they feel quite held by that. And then the other way round, following an assessment, a lot of people with both, whether or not actually they meet criteria, they're experiencing difficulties, and they often are looking for support or therapy after going through an assessment process. So yeah, it's a very integrative way of doing it. The other thing to say is, in terms of triage, sometimes people will phone us, and Lisa and I speak to every single referral that comes through. Sometimes people don't know that that's what it is, ASD or ADHD, and through the course of those initial conversations, sometimes Lisa and I might get a sense of it, and we can offer them, as perhaps as well as therapy, an initial screening, you know, and we've got a helpful, what I hope is a helpful case study of just such a referral that came in that way and ended up being a case of ASD. So that's a bit about us, and I think Lisa's going to talk through what we're going to cover this evening.
Yes, so the first bit is around understanding the key definitions, I suppose, not just the diagnostic criteria, but what we mean in the current definitions of both ASD and ADHD. And we will be focusing in the adult population for this event, largely because that's the cohort that we work with, and there's also different information regarding adults. And alongside that, we'll think about the reasons why these diagnoses are being picked up in adulthood, which is why the demand is quite high at the moment for these assessments. We will discuss best practice for the assessments, and we'll also think about digital delivery and how that can play a role in these assessments. So I wanted to start off by thinking about sort of language around ASD and ADHD. You might have come across the term neurodiversity or neurodivergent, and these are terms which are around now, and really they're phrases and terms that we can use. Neurodiversity is really a way to describe a community of people. It's the concept that people have natural differences in the way that they might think and the way that they might behave as well. And neurodiversity actually encompasses not just autism spectrum disorders and ADHD, but other difficulties as well, including dyslexia and dyspraxia. So it's a sort of phrase to describe a community of people. Neurodivergent describes somebody who behaves, thinks, or maybe learns differently. So that's thinking more about describing someone. Put a couple of statistics in there. So around 1 in 100 people in the UK thought to have ASD. And then if we look at the statistics around ADHD in children, and again, it's different, the information that we have between children and adults. In children, it's slightly higher, thinking around 3 to 6 in every 100 children. And then in the adult population, it's thought to be between 3 and 4%. And that includes people who might not be diagnosed. So it's a sort of estimate, and it's difficult to be precise about those statistics. So thinking about key definitions, and particularly with ADHD, is a nice sort of clear description here about it being a condition which affects people's behaviour. And this is taken from the NHS website. But people with ADHD may seem restless, have trouble concentrating, and may act on impulse. And what that definition highlights is the 3 key areas of difficulty that people have with this diagnosis. So attention, hyperactivity, and impulsivity are 3 key factors in this diagnosis. It can often have a big impact on people's lives and can impact people in different areas, so not just social settings, but also at work, and thinking about in their personal lives as well. And in fact, to achieve a diagnosis, people have to be experiencing difficulty in 2 or more of those areas. Some of the things that people might experience and are part of the diagnostic criteria are difficulties with attention, so sustaining attention. People describe being easily distracted, sometimes feeling sort of restless or forgetting things, making mistakes, fidgeting and being physically restless, talking excessively as well. And sometimes people struggle with things like waiting their turn to speak or knowing when the right time is to speak. Femke's just going to talk through the key definitions and descriptions of ASD.
So autism spectrum disorder is, as it says here, a lifelong developmental disability, primarily affecting communication and interaction with the world, and particularly with the social world. It is a spectrum. So there's a lot of variability even within that diagnosis. There's differences between the genders and across age groups, and diagnosis in adulthood is obviously complicated by the fact that a lot of people who have not been picked up with autism when they were younger have learned to mask various behaviors associated with it. So it's quite a skilled task to get underneath that. The key indicators there are social communication and interaction. I'll talk a little bit more about this on the next slide. Restrictive interests and repetitive behaviours. Those are the 2 main ones, but also it's very common to have, I guess, what we'd call unusual sensory sensitivities. And as Lisa was explaining with ADHD, these must limit and impair everyday functioning, because it is a spectrum, and there'll be lots of us that identify with bits of that at times in our life, but not to that extent. And that's the key. In terms of the statistics, there's about 700,000 people in the UK with ASD. That is almost certainly an underestimate. And there's a lot of comorbidity between ASD and ADHD, as you can see there. Again, it's a little bit hard to know exactly what the figure is, but it's significant. Could I have the next slide, Lisa? Yeah, so just pop this up there. DSM-5 actually changed the diagnostic criteria slightly for ASD. We used to talk about a triad of impairments, and certainly when I trained, that was what we learned. But it's now a dyad between social communication and reciprocity down there, and the stereotype, repetitive and rigid behaviours as being the sort of two main areas. And what do we mean by that, really? Well, with social communication, it's taking things literally, failing to read the cues that are out there in people's tone of voice, in facial expression, in body language. It can be very hard to make friends as a result of all of that. Doing things that appear inappropriate puts people off. And you can sometimes come across as being insensitive. So you can imagine some of the difficulties that can come from that. In terms of the repetitive and rigid behaviours, these can be all sorts of things, but they develop primarily because the world is experienced as it is unpredictable, but that's very difficult for a lot of us, but particularly for somebody with ASD. And these behaviours can help just restore a sense of calm and control. It is key part of the diagnostic criteria that this is lifelong and pervasive. So you do have to demonstrate these difficulties existed in childhood, and we'll talk a bit more about how that's done in a minute. And as I said before, it has to be a clinically significant level of impairment in functioning. The sensory sensitivities that are no longer as key under DSM-5, but are very common, tend to be just overstimulation to things like noise, people, and the more people, the more overstimulating it is, bright lights and all of that sort of thing. So that often leads to people avoiding those kinds of situations, which can make them appear antisocial. And actually, a lot of people with ASD are actually not antisocial. They're trying to avoid these very difficult sensory overstimulatory experiences. So why are these diagnoses only being picked up now? Well, I mean, I guess the obvious thing is that both of these things are much better understood now than they were 20 years ago, and certainly 30 years ago and 40 years ago. Many people would have slipped through the net. And I don't know about you, but if I think back to my school days, I can think of children in my class that probably would have met criteria for these things, but if they were diagnosed, it was certainly not to anyone else's knowledge. And luckily, these things are being picked up much earlier now, but we have a huge cohort of adults who kind of missed that. But there are also lots and lots of adults. We see a lot of young adults in the service, sort of university students, and that kind of thing, and actually parents, where they were sort of muddling along, masking things, never really understood that, and neither did anybody else when they were growing up, and sometimes it gets picked up at that sort of early, when they have to leave home, and the supports that were there that were perhaps masking the difficulties aren't there in the same degree, and they can't actually function in adult life independently. And I mentioned parents. We do get a lot of parents or for both ASD and ADHD whose child is diagnosed, and then they will say to us, I'm pretty sure that I would meet criteria as well. And it's that sort of brings it to their attention. I mentioned about masking. you know, there's a high proportion of people who are very high functioning, high levels of intelligence, and who are aware that they're struggling with these things, and perhaps were aware when they were younger as well, and developed techniques to mask these difficulties, which in some ways is very adaptive, but it can come at a huge cost to the individual. It isn't that they wouldn't meet criteria. It's also important to say that both of these, ASD and ADHD, are underdiagnosed in women. That I think that is shifting, and there's a lot in the media about that now as well, which is a good thing. But it is important to note that there can be some slightly different presentations between genders. And we've just listed a few of the things there, or some of the reasons why an adult who perhaps has now left the education system might seek a formal diagnosis. So getting resources and support is a key one. Validation is the one that everybody talks about to us. I finally get a sense of, I can understand that, you know, that it makes sense of a lot of the difficulties that they may have experienced. And that's quite emotional for a lot of people in adulthood to get that diagnosis. There's a lot of, if only I knew that earlier, if only my parents knew that, if only my school teachers had known that. And, you know, that often requires some support. On a positive note, it can also help to validate the strengths that are there. And we certainly do that as part of our assessment and recommendations, as well as the areas of challenge. A lot of people like to link in with other adults with a similar diagnosis. They find that quite validating, and we will provide them with recommendations and links for that. And then critically, on a more sort of functional level, it can really help with conversations with those other people in those people's lives. At university, lecturers, tutors, we're always having to send copies of reports in to various universities, to employers, occupational health and HR departments. We do quite a lot of work with people's partners as well. They will often come in the feedback sessions. They usually, understandably, have a lot of questions for themselves. It can be a really key thing in a relationship. It can explain a lot of the difficulties that might be being experienced on that level. We also do a lot of work with parents of adults who are often having to do more parenting for longer for people who have these difficulties, and it can be very validating for parents as well. Finally, I think sometimes the diagnosis alone can just help somebody formulate, I guess we've put articulate here, but formulate their difficulties in a more helpful way.
So thanks, Femke. And to the point on that slide at the top as well, I think, is it fair to say, Femke, that there is a lot more understanding, and often in workplaces now, there's sort of awareness campaigns around these diagnoses. And I think sometimes that leads people to then consider themselves in a way, and I think that's affecting the demand that we see as well. So sort of following on from that, thinking about, well, how do these diagnoses affect people's lives and mental health as well? So whilst these diagnoses aren't mental health conditions in themselves, they can impact people's mental health and their mental health needs. And you'll see some of the stats on this slide quite high in comparison to the general population. There are higher rates of mental health difficulties in adults with autism spectrum disorders. So one paper from 2008 said it's around 77% of young adults, so thinking sort of 18 to 25, might experience something like an anxiety problem, low mood or depression, or another mental health problem. There's other evidence as well which supports that, and obviously, you know, diagnoses has to be accounted for these figures as well. There is some research to say that young people with ASD have much higher rates than of mental health difficulties than their peers, most commonly social anxiety difficulties. And if we think about that, and given what Femke said on the previous slide about presentation and diagnostic criteria, it's not surprising that that figure is so high. If we think about sort of that in a bit more detail and what's underpinning those mental health difficulties, often it's the fact that there are unmet needs relating to neurodiversity. So it could be that the environment that the young person is in, or the adult is in, makes it difficult for them. It could be that they struggle to fit in, or to understand how to do that, and that might lead to some feelings of low mood or shame, or even loneliness, which can impact the risk of mental health problems developing. Having a timely diagnosis is really important. The reasons we spoke about earlier, but also in terms of mental health, because that framework for understanding oneself can have a huge impact on somebody's mental health, and for other people to understand them as well, which is obviously a positive factor of being understood. So a diagnosis can actually be a protective factor for mental health. And when somebody's known to mental health services already, having a diagnosis can also support people in understanding, well, how might we work best with this person? What sort of support do they need? And also being mindful of sort of medication needs and particular types of therapies that might not be best suited to that person. So for those reasons, diagnoses are actually helpful in thinking about someone's mental health in a holistic way as part of their experiences. So Femke's going to talk a bit about the sort of iceberg model of thinking about ASD.
Yeah, this is a slide that was actually put together by Dr. Lizzie Cock, who heads our ASD, adult ASD assessment service. She also works 4 days a week for a specialist ASD service in the NHS in London. And I just think it's quite a helpful analogy to say that it is a bit like an iceberg in that often if you were to come across someone with ASD, it would be understandable that we would just focus on the tip of the iceberg and the things that you see. So, for example, that they've got some sort of communication problem, they seem a bit rigid, stereotyped, and just odd. And that can lead to those things over there on the right: stigma, isolation, being labelled as aggressive or unfriendly or rude or something like that. And there's a lot of it can lead to a lot of comorbidity, of course, if that's what the person is experiencing. Below the surface, obviously, the bulk of the iceberg are the reasons that are giving rise to those behaviours that you see. So the fact that that person's actually struggling with theory of mind, or just finding it very difficult to put themselves in other people's shoes, and certainly not on an instinctive level. They're finding it hard to get the gist of things. They're struggling with sensory processing. They might be struggling with planning, organising, other executive function problems, and emotional regulation difficulties, leading to all sorts of things like outbursts, and again, more behaviours that might lead to stigmatisation. So if we sort of shift our attention to that and in helping someone understand and develop skills to manage those things, it can shift much more to somebody being able to develop helpful coping strategies and realistic expectations, perhaps choosing certain environments over others, meeting more like-minded people. I guess basically steering their life in a way that's going to enable them to bring out their strengths and to minimize the things that they find particularly difficult as far as they possibly can. So I think it's I've just found this quite, when you know, Lizzie explained it like this when we were setting up the service, I quite liked it, so I thought I'd share it.
So I'm just going to spend a few minutes thinking about differential diagnoses, which is part of a screening appointment. I suppose part of the reason for doing that is to think about what other diagnoses might explain how the person's feeling and what they're experiencing. So there are lots of differential diagnoses actually to consider for both of these, both ASD and ADHD. So there's a lot of overlap with anxiety disorders, bipolar, substance misuse, sleep disorders as well, and low mood, but also some physical health difficulties can also account for some of the things that people experience and the way that they're describing their behaviour. So we were chatting earlier about menopause actually, and some of the physiology that people experience and how that could be understood and could be potentially differential diagnoses as well. So there are lots of things to consider in a screening appointment. That's why it's so important to be thinking about all areas of someone's life and their physiology. There's also a lot of overlap, as Femke mentioned earlier, between ASD and ADHD. So there can be differential diagnoses between these two categories as well. Really important for those reasons that assessments are done by people who have an understanding of I suppose all of these things, but particularly both ASD and ADHD. So there's a sort of smooth pathway for people if they need a different type of an assessment.
Yeah. Is it worth saying, Lisa, we should maybe just explain that we do, for everybody, both our ADHD and ASD pathways, we start with an initial screening appointment, which is invoiced separately. It's a standalone appointment. There are some measures that go out, which we receive back, review, and then meet with the individual. And the purpose of that, it does kickstart the assessment, and the information that we get from the screening does go into the main assessment. But we feel that it's really important in case it is actually, no, this is an anxiety disorder, or actually there's, I don't know, there's a unprocessed bereavement that's leading to all sorts of behavioral symptoms, and or you know, so that somebody's not, because these assessments are expensive. There's a lot of clinical time that goes into them, and we don't want people to have to embark on that if actually there's a more helpful pathway that we'd recommend. And most of our referrals do go forward, but they don't all go forward. And so it's just a sort of stage that we put in to kind of catch that, and then be able to support people in the right way without going through a full assessment if it's not needed. Yeah,
I suppose that's the other thing, isn't it? It gives people time to think about if they want to go through with the full assessment as well, and to adjust if there is enough, you know, evidence to warrant going through with the full assessment. Can give people time to think about that and adjust to thinking about what that might mean for them, and you know, do it in an informed way. So it's a really good, find it works really well, don't we, the screening, for lots of reasons, and particularly the differential diagnoses bit. All right, so we're going to think about what it's like being with someone with either ASD or ADHD. So put some quotes here which aren't from anybody in particular, but almost our sort of collective knowledge of the sort of things that people experience in their day-to-day life. which is probably more helpful to think about than in some ways the diagnostic criteria. It's what's the lived experience really of somebody with ADHD. So my mind is constantly whirring. Others think I'm just disorganized. I'm the one who always turns up late. And sometimes I feel brilliant, and other times I feel like I'm on another planet. I think all of these things help us understand what it might be like for people who have ADHD and what it feels like to them. There is a brilliant film of 5 minutes, and I put the image there on the right. You can search for it. It's called A Day with Hannah and Doodle. I would highly recommend watching this. It's made by a brilliant team who were inspired by their family and friends who live with neurodiversity, and they made this 5-minute film to illustrate what it feels like to have ADHD from the view of a child, and it's all done to music. It's absolutely brilliant, and it gives a real understanding of the experience of this character Hannah, and it kind of follows her through as she forgets the task, which I think it's her homework, and she gets distracted and goes into a sort of imaginary world with her friend Doodle, who is the one holding the pen. And I think it's just a really nice way to understand it by watching something. So I would encourage you to take a look at that when you've got a few minutes. Femke's got an equally interesting video. We might try and play it.
We're going to try and play it, just because once I start fiddling with it, it'll just pop up and start. It's quite short. It's only 2 minutes, maybe 2 and a bit. It is quite loud, and that's deliberate. So I'm not changing my volume settings. It's supposed to be. So it's supposed to give you just a sort of a sense of what it's like to have sort of sensory overload, particularly to noise and sound, which is only one part of the experience of ASD, of course, but it's just an easier thing to deliver in this particular setting. So bear with me. Going to let me do it that way. Now I have to turn on the sound, don't I?
Yeah, we can't see the video just yet.
No, that's okay, it's coming. Bear with me, I have to do that bit first.
Yeah,
right.
There you go.
Okay. Okay. I don't know about you, but when I watch that, I just want someone to turn it off. It's really quite uncomfortable and quite emotional, actually.
Yeah.
Just like our fingerprints, all our brains
still hear
are
that?
unique.
Yes.
But for the majority of
Apologies,
people,
let me
their
just,
brains are similar enough that there are largely no obvious differences in.
Okay.
But I think also at the end, seeing the young person there and the impact of all of that, you know, and sort of how overwhelming that is, you know, it's a really good sort of example, isn't it, of what that lived experience. Yeah.
Yeah. I was struck by one of the clients that we had through for an assessment. One of the I guess anecdotes that Lizzie mentioned was that there was a lady who was worked in an office, and there was a buzzing light, you know, a sort of strip light that kind of buzzed, which over the course of a typical working day, she would spend up to 2 hours in the toilets, just giving herself that kind of downtime, and she just thought that was, you know, something she had to do. She, you know, and it's incredible when you actually get into the detail of it, that what people are trying to do to cope with the everyday life. Yeah.
Right. Shall I share my screen again, and then we can come back. So any other thoughts or questions about that video? Right. So I think you're going to talk now, can't you, about a case study?
Yeah. So this was we've called him Adam, obviously not his real name. Somebody we had through this year in the ASD assessment service, and it actually initially came in as a referral for therapy, and it was Dad who phoned us, quite upset. Dad was. Adam was 19, and he said to me, we're all over the place. I think that he might be psychotic, or he might have OCD. He's just really, really distressed, and he's really struggling now. He's starting to bunk off work. Been to the GP, had actually been assessed, I think, by a psychiatrist through the NHS, and then was on a waiting list. And the psychiatrist thought that it was psychosis, because one of the symptoms was loads of anxiety about passers-by by the house, wanting to, or he was worried that they might want to come in and burgle or harm people. And he was struggling to sleep as a result of that, lived on a busy street, and they thought it was paranoia, and had actually written a prescription for an antipsychotic medication. And Dad said to me on the phone, he said, it just doesn't feel right, to me. So we had a chat about Adam. We took some sort of brief history on the phone, and Dad was saying things like, we've never known what to do with him. He's always struggled. He was bullied at school. He had no friends. He's always found life very hard. And the more that conversation went on, it just started sort of dinging in my head, which is these things that happen when you take these initial phone calls. Oh, I wonder if there's ASD there, from some of the things Dad said. So I mentioned that very tentatively. It's always difficult to introduce that, particularly over a phone call. And I said, I could well be barking up the wrong tree here. It's just a few things you've said. I'm just wondering about that. And in any case, let's get Adam in for an initial assessment, but let's do it with Lizzie Cock, because then she can go either way. She's a brilliant clinical psychologist, and if we're barking up the wrong tree with that, she'll be able to do a very good assessment nonetheless, and support him. so he came in, and Lizzie did a screening assessment, and you know, it was pretty clear. She said to her after that there would be ASD present. So they went forward to the full assessment, and he certainly did meet criteria for that. So I think Lizzie did 3 or 4. We always include two feedback appointments anyway in the sort of assessment protocol. But I think Lizzie met with him for 3 or 4 additional sessions, one of which was just a parent only session to support him with making changes in his life. So at the time of referral, Adam was working on a building site. So it was a very loud, noisy, unpredictable environment. And not coping with that. So one of the things that happened is they thought about different sorts of employment, and I'll come back to that in a minute. Did a fair amount of work on understanding the diagnosis and what that meant for him, going over some of his early life experiences at school, for example, of being bullied, and why that might have been, and what that meant to him. Mum and Dad needed support around this as well. There was a lot of, I wish we'd picked this up earlier. Why didn't we? So they needed a lot of support with that as well. Adam was somebody, so he had sort of these 3 or 4 sessions, and didn't actually then require and he certainly didn't need antipsychotic medication. Anyway, so that was concluded probably, I don't know, 4 or 5 months ago, something like that. And actually this week I had a message, a phone call actually with Lizzie about something else, and she said to me, I have to tell you, guess what happened to me in Marks and Spencer's? And I said, oh, and she said, I popped in to get a sandwich at lunchtime, and do you remember that case? The young man who was so distressed, and I forgot to mention this, that he was actually stabbing himself, bless him, in his thighs. He was so distressed and so lost, so overwhelmed. And of course, I did remember that. She said, he was in Marks and Spencer's. That's where he's working now. I said, oh, right. She said, I was waiting in the queue, and I was watching him help a customer. He spotted me. He smiled at me and waved. And she said, literally in that moment, my whole year, she said it was just one of those, thank goodness, all these things kind of aligned. Okay, Dad had the wherewithal to ring up and have the chat. We had the chat. We were able to triage him into what turned out to be a really helpful pathway. He then had all the support from Lizzie and his who knows what happens next, but he seems to be in a much better place. So I just wanted to kind of share that story, because it's you can sort of think, and Lisa and I were talking about this, we sort of said, the whole sliding doors, if that hadn't have happened and he was on quite heavy hitting antipsychotic medication and encouraged to go, I don't know, back to his previous job, which wasn't working for him, without any of this understanding, and with all the difficulties at home, nobody understanding. So yeah, it's a story with a happy outcome.
Thanks, Femke. I think there's also a clear message, isn't there, about understanding has power, doesn't it? Understanding ourselves and understanding each other has a lot of power in life. So we're going to think about best practice in assessments, and in that we're going to talk a bit more about how we do assessments as well. So you're going to just run through the ASD.
Yeah, I mean, the NICE guidance is basically these three stipulations here. So there needs to be a clinical interview to obtain lived experience information, on symptoms now. There needs to be involvement from a third party. so we can gather reliable as possible information on developmental history, and also to get a view of that client's presentation in a non-clinical environment, so at home. So it's not uncommon in adult ASD that we will speak to certainly a parent, and if they are around, also a partner that the person's living with now. And then finally, there needs to be clinical observation through a validated measure such as the ADOS, which is the one that we use here at the clinic. And I added in this slide, so this is from one of the main London NHS trusts who are overwhelmed with requests for assessments and referrals, so are outsourcing some of their assessments. And this is these are the criteria that they, sorry, I don't know why they've all got number ones by them, but they that they are looking for when they're trying to assess a service to see if that's a suitable one for them to outsource to. So obviously it has to be in accordance with NICE, but beyond that, it must consider complexity and differential diagnosis. And it states, therefore, that the person doing the assessment should have a broader working knowledge of psychology. And typically, typically would be a clinical psychologist or a specially trained counselling psychologist, and to be mindful of diagnostic overshadowing. And the service must include feedback. So there must be a feedback session. That sounds obvious, but there are clearly services who don't offer that. And there must be an option for post-diagnostic support. And the case study that we just went through about Adam, they ended up having 3 or 4 sessions, which isn't included in the sort of set piece of the assessment. I think 1 or 2 sessions are, but we always offer it if it's needed or wanted. And finally, it must involve seeing the client at least once in person. So there are services out there that do the entire assessment virtually, but that isn't actually that does actually meet NICE, but it isn't gold standard. Certainly the ADOS can't be done that way. Other measures potentially can be, but so I thought that might be helpful. And I think, Lisa, you've got something similar on ADHD, haven't you?
Yes, so similarly, the assessment for ADHD would need to be completed by somebody who's trained, which again sounds obvious, but it needs to be a competent clinician with expertise in ADHD, and slightly different with ADHD in that they need to be assessed as an adult. So if they've had a childhood diagnosis, but the difficulties are continuing into adulthood, then that would warrant an adult assessment, which is slightly different to a child one. So it would need to include a sort of clinical, but also psychiatric history, thinking about mental health problems in the past, and also developmental history. So usually the symptoms might have been present before the age of around 12, and that's why it's important to take a really clear history, not just of the developmental sort of aspects, but also physical health and mental health problems, thinking about those differential diagnoses as well that we spoke about earlier. Risk assessment is really important because you have got a higher risk of mental health difficulties. That should be part of an assessment. So thinking about the person as a whole, and any report would also include sort of advice about needs and support. ADHD assessments usually include a diagnostic interview. We use the DIVA-5, and that is a sort of systematic way of exploring current and childhood symptoms. Sometimes information is needed from relatives or people that know the person well. We also actually use a computerised based screening as part of our assessment, and it's called the QB. It on its own, it can't be used to diagnose ADHD, but we use it to inform the rest of our assessment. And as we talked about earlier, that there needs to be an evidence that the symptoms have an impact on the person's functioning in 2 or more areas on their life. So it's important to explore those and then think about a clear conclusion from the assessment as well. So just a note about digital delivery. So we do actually complete our ADHD assessments online. So we complete them through video, mixture of video sessions, phone, and obviously sort of the computer-based screening is done by the person independently, and then we look at all the information together. And there are actually lots of benefits of doing the ADHD assessments remotely. I think it can be easier for the person to organise their time, for them to attend. There are different parts to the assessment, so it's not all done on one day, and that sort of limits the amount of appointments they need to attend. And the QB check can be done by the person where they are as well. So there are lots of benefits from doing it digitally. But as Femke said, with ASD, one of the components we actually do in person, and I think the rest we do either by phone or video sessions. So that's fine. But the ADOS we do in person.
Yeah, Lizzie often does the feedback face to face, but it doesn't have to be done that way. Yeah.
I suppose it's also about the preference of the person and what might work for them in terms of communication. Something to consider with all of these assessments, you know, that people might have a preference for different things.
One thing that we have learnt, which we knew theoretically, but it's always I don't know, it's always interesting when we have it confirmed through our experience, that with the ADHD service, it's critical that we have lots of reminders, lots of prompts, lots of follow-ups for have you completed this questionnaire? Rachel, our clinic manager, works very hard on keeping people on track. They forget the links to their appointment, they forget the times, so we you know, it is sort of the nature of what we're working with, but in structuring a service around that, yeah, people need lots of reminders.
Yeah. So the final bit is just thinking about, well, how best to support people, and I suppose not just professionally, but thinking about if there's somebody in your life and a personal relationship, or somebody that you know, somebody you work with, that has a diagnosis or presentation or identifies with having ASD or ADHD, thinking about, well, how can we support people? I suppose the first thing is thinking about acceptance, you know, acceptance that there are natural differences between people. And the way we can support people then is to ask and to learn what works for individuals, you know, ask questions about how we can help others, or how we can explain things, and how we can change our communication to help other people. In the workplace, you know, these diagnoses would actually fall under sort of reasonable adjustments, being of benefit. So that needs to be personal. We've put some examples here, but everybody is different. Given these are, you know, natural differences, but people are also very different even within these groups. So you need to think about, well, what does that particular person need? It's best not to make assumptions in a workplace, but identify what would help those people. Examples are things like, you know, allowing people to work flexibly, giving structure or chunking with tasks, giving reminders, breaking things down, allowing more time for processing complex information, or having things written down or in a visual way. And again, these are just examples, and it would be down to what helps that individual person. But we know that when workplaces are inclusive, and people's differences are accepted, and differences in personality, but also behaviour, that environment can help people thrive, both socially, but also in terms of their performance. So I think we've come to the end of our presentation, and we've got time now for questions or just discussion about anything we've said. I'll also stop sharing and stop the recording, so people can feel free to ask those questions.